joining this call, and a special thanks to Dr. Chen and Dr. Hochman for agreeing to present today. I just want to mention briefly for those who are new to the series that the intent of this call is to this is a call that's supported by the multiple clinical translational science initiatives in Los Angeles County, including the one at USC and also at UCLA, and also our regional counterpart, including the CTSI at Riverside. And our intent in this series is to highlight over this series of calls a couple of things. One is to highlight what methods local researchers and partners are using in the area of implementation and dissemination sciences, to those methods, learn from them, and also to identify local examples that we can all learn from to advance our work or to engage others in this kind of work, and think about what capacities we are all developing locally that could support more of this type of research, and what resources there may be that we can take advantage of. And sometimes that's methodological expertise, and sometimes those are capacities that partners or universities are developing that we should all know about. So we just want to remind all of ourselves about what the purpose of these calls are, and also to invite anyone who's thinking about a possible presentation they could give to contact us and let us know. So a little bit of promotional there. So I just want to then hand it over to Dr. Chen and Dr. Hochman, and perhaps I think that what we'll hear today is some examples of DII science, and I wonder if we could also ask you as part of your introduction just to talk a little bit about where you're situated at USC in terms of your Implementation Science Center, and if you want to talk a little bit about where you came to this work, past experience, that certainly would welcome those kinds of comments as well. And so I'll hand it off to our presenters, and thanks again.
Thanks for the introduction, and thanks for the opportunity to speak. And you want to start off since you're the first?
My name is Steven Chen. I'm chair of the clinical pharmacy department at the OC School of Pharmacy. I've been in the primary care field for just about my career, and just in the last 10 years have worked specifically on and programs for the underserved. I was to partner with Dr. Hochman on some of the work that you'll see shortly. And I think when I think about the issue of whether our work is innovative or implementation science, I think it's right in between. I think pharmacists are largely underutilized in the healthcare system, and I think Dr. Hochman and I have worked out some nice processes that help to make this process of implementation much easier in any setting. So I'll leave it at that. Mike, why don't you go ahead and introduce yourself?
Sure. So Michael Hochman. 3.5 years I've been medical director for innovation at AltaMed Health Services, and I've been physician champion and site lead for this Medicare Innovation Challenge grant. And, it's really been a learning opportunity for me. I initially had always thought of pharmacists as the folks that you see in CVS and Walgreens doing retail work, and I was able to see a new way in which pharmacists can be used. And actually, the dean of the pharmacy school was quoted in the Wall Street Journal article that covered our city as saying the pharmacists are the most overtrained yet underutilized healthcare professionals. And I think to sum up my sentiments in a nutshell, that captures it pretty well. And we've given this talk, I think it was even last year, on this implementation science webinar series. But I think there's sort of a nice or interesting, I'm not sure, nice, we'll discuss it, epilogue to the story about what happens to innovations when grant funding ends and some of the compromises that you have to make. And I'm going to talk a little bit about the Gehr Family Center for Implementation Science now that I'm no longer at AltaMed and helping to start this center, but I have a few slides on that in the end. So with that, let me turn it over to Steve and have you kick with an introduction to the CMMI grant.
Great. Thank you, Mike. I'm going to confirm. Okay. The outline for the presentation is basically we'll talk about the CMMI program, and then Dr. Hochman will go through the business case and summary of the Gehr Center, which I think you referred to previously. Next, please.
Dr. Chen, just let me know when you want me to advance to the next slide.
Okay. So just for brief background, I think all of us are aware that medication-related problems are the cause of injury, hospitalizations, deaths, much of which are preventable. Patients are injured each year due to medications. I saw a statistic recently that million deaths are accounted for by medications. One for outpatients experience a side effect, but the bottom line is almost every chronic disease requires medication as first line. We can't get these medications, we just need to figure out how to use them better. And we spend about $374 billion a year on medication, and some of the recent reports from the New England Healthcare Institute indicates that there's about $290 billion of avoidable medical spending that's attributed to suboptimal use of medications, costs such as extra emergency room visits, extra physician visits, hospitalizations, and so on. Next slide, please. Project funded by the Center for Medicare and Medicaid Innovation started back in 2012. We wanted to work with a partner that was able to get us a large set of data, probably one of the most important things in this project, but also was open to the idea of integrating clinical pharmacy service into the healthcare system. The concept became to come up with teams, and we keep this team very carefully. I think innovation is common that works well, but also something that is cost effective. So we very carefully came up with a composition of a pharmacist who is clinically trained, had completed a residency, a resident in training. So this is a doctor of pharmacy who is in their first year out of graduation and is training to become either a primary care or other specialty pharmacist. And in the pharmacy world, there are very few residencies relative to the graduates that want residency. So in general, people get residencies are tops in their class. And there's something called a clinical pharmacy technician, and this is basically taking the functions that occur day to day in the course of caring for patients, and those don't require a doctor of pharmacy degree, we gave to the technician. We created a curriculum to train them on things like the individual elements of med reconciliation and review. They helped us comb through our triggers, which I'll get to in a second, to identify high-risk patients. They solicited patients cold call. They were great at it because they were basically the population we were trying to seek. They're all Latino, and most of the patients we enrolled were Latino. They were just fantastic, and I'll talk about some of their other functions later on. We came up with 10 of these teams. They are located in AltaMed clinics in LA and Orange County. 3 of the teams were in PACE centers. The rest were in the general medicine locations. The 11th team is a telehealth clinical pharmacy team. So this is the same thing, resident pharmacist and technician, but instead we were tapping into a couple of AltaMed patients that were too small in size or had too limited volume of patients to warrant having a full-time team. Basically wanted to demonstrate that the care delivered by video telehealth would be just as good in terms of quality and patient satisfaction and outcomes as in person. And with our data that we collected that we are compiling now, we're showing that indeed is the case. We actually increased the number of pharmacy residents who were trained. We partnered with three colleges for technicians, pharmacy technicians in Southern California. And with our curriculum, they've now taken that curriculum, they've integrated it, so now they are able to graduate these technicians with the skills necessary to support pharmacists working in this setting. We did a web-based tool, and the intention of this tool is to help pharmacists who have not been in care settings, for example, pharmacists that have maybe been working in community settings where their primary role was largely dispensing medications, and all of the skills and competencies needed to begin the process of starting to work in these settings. So it's about 40 hours worth of online material. Afterwards, it requires an on-site OSCE demonstration of competency, and then they'll get a certificate for that. Outcomes are all AAA aligned: cost, quality, safety, provider satisfaction, patient access. And then as part of our grant, we had to try to spread this work, our learnings of this work, during the grant itself. So we're hosting a meeting every 2 years where we're using best practices in pharmacy and provide services from across the nation. Please. It was pretty focused because we knew that there's not a lot of time to demonstrate outcomes in the primary care setting. So after the expensive patients, the patients who were frequently hospitalized, the patients who were recently hospitalized as well. And then we actually came up with about 4 dozen embedded triggers or algorithms. These kind of medications, problem lists, demographics, vital signs, tests, and put together, they would suggest gaps in medication-related quality or safety. So an example might be a patient with systolic dysfunction, not an ARB, not a beta blocker, that sort of thing. Then take that list, which would be run monthly through AltaMed EHR. It would go to each of the teams. The teams would vet it with the current medical record. There was indeed a gap confirmed. AltaMed was gracious enough to give us the privilege to self-enroll patients and inform primary care providers. And there was zero pushback from that. I think the primary care providers were very happy that we were helping them identify patients who could have some improvement in medication therapies. These initial triggers would help us teach physicians in a sense of the types of patients that we were looking for, and within the first couple of months that happened so very quickly. By 2-3 month mark, the majority of patients that are being enrolled in our program were direct referrals or warm handoffs from the physicians, and found that many of those patients were actually on the trigger list. We just weren't able to get to them, or weren't able to get to them yet at that point. The service we provided is comprehensive medication management, and I think some of you know what medication management is. It's a little bit different in that comprehensive medication management looks at all patients' disease states, all medications, ensures that as appropriate, patients taking the meds as they should, and that through a collaborative practice agreement ensure that we follow up with patients and until patients reach treatment goals. So if patients don't reach treatment goal, again, we keep seeing them until we get to that point. If they do, we still don't cut them loose too far. Every 2 months, our clinical pharmacy technician checks in with the patients through a phone call. The check-in is a yes-no checklist we came up with that goes through adherence, self-management behaviors. The technician goes to the computer and looks for key markers that we ask them to look up. And if there's anything that looks like it's going the wrong way, the information is given to the pharmacist, and the pharmacist considers re-enrollment of that patient. And we did this because most programs that improve patients' chronic diseases, once they're discontinued, patients often fall into poor control. And by doing it this way, we found that we were able to keep patients in control. Next, please. Enrolled over 1,000 patients in this program, largely Latino, mostly women. 3/4 with hypertension, about 1/3 uncontrolled, 2/3 with diabetes, more than half uncontrolled, and we had relatively high rates of hospitalizations. Next slide, please. Early mentioned, and this is still growing, and I think I just got a recent update not more than a week ago. But for patients with blood pressure out of control, a baseline somewhere in the mid to low 150s systolic, and somewhere in the mid to high mid 80s in the systolic. Almost all of those patients were at goal, and you can see that as we took that mirror over time, we found that they remained at goal. And I think that's largely because of that role of the technician we had, checking in to make sure the patients continued with their adherence and self-management behaviors. Next slide, please. Very A1C. Initially, a lot of right shift, double-digit A1Cs. Within the first 6 months, you see a left shift, and then that continued over time. In the end, we found that we were, I think, almost 2 points better than the control cohort in terms of A1C improvement. Next slide, please. Hospitalizations indicated that as more time passed, we saw lower rates of hospitalizations, but slide, please. Evenly, when we applied a propensity score matched comparison with a cohort group, slide, please. Differences that were pretty important. A1C differences of about 11%, blood pressure 9.3%. And looking at readmissions, these are patients who were admitted prior to entering or enrolling into our program. We saw that overall in the following 6 months, we saw a difference of 16%. And again, this is the propensity score matched comparison between our patients patients that had never received comprehensive medication management. When we looked at those admissions that were medication-related, it was a 33% difference. Next, please. Data. So I know that Dr. Joyce and his team is continuing to look at it, but when looking at mortality, we saw over time about a 25% absolute difference between patients CMMs that did not. Next, please. That comes up a lot is what was done for these patients that's different from other programs that might involve other healthcare disciplines. And I think the key is that we focused on medications. We logged over 67,000 drug-related problems of 10,000 patients. It's over 11.5 medication-related problems per patient. And the most common problem we dealt with was appropriateness and effectiveness. And this would mean maybe doses were not quite adequate to reach treatment goal. Perhaps based on the patient's comorbidities or other medications, there might have been another medication that would be better for that patient. So more often than not, and as you'll see the next slide, we were, thanks, maybe we show the next slide. Thanks. We were changing dose of medications, adding medications, or substituting medications much more commonly than we were discontinuing medications. And to wrap up the previous slide, there was about 20% rate of medication misuse or adherence, and about 20% of these were safety issues. This would be adverse drug effects that were identified and resolved, or potential adverse drug effects that were prevented. Next one, after, please. We measured physician satisfaction using validated tools, and we did it both in the end of the first and second years. And overwhelmingly, the physicians seemed very happy with the service. We had physicians who were part of cohort sites that had not received any of these services to refer patients into our clinics with services. So I thought that was a pretty good sign of satisfaction. Next slide, please. That in CAP surveys, the highest score possible would be somewhere around 9.6, and I'm happy to say that our first and second year scores were 9.6 and 9.7 respectively. So patients were overall very happy with the service as well, and we got very nice letters addressed to us and the CEO of AltaMed praising the value of these services. Next slide, please. So certain things I think that we've been sharing across the country as teams ask about how this might work for the settings were some things that we identified as key for engaging patients and retaining patients. So some of the things I talked about, the warm handoff, where when a primary physician endorses the service and literally walks a patient over to us, that is by far the best way to engage a patient versus a phone call. Although I have to say our technicians are pretty good at the phone calls and relating to those patients. We tried to build some room in for walk-ins, as I know physician services do as well, because it's great if you could see the patient that day and get them engaged rather than trying to reschedule them and have them come back at a different time. I mentioned before, because our technicians are Latino, having that bond, having that cultural competency was golden, I think. We aligned appointments as much as we could, so whenever we had patients come in for a follow-up, we tried to the time when coming in anyway as much as we could. We engage family and caregivers if it's apparent that the patient needed some assistance. Very rare home visits, but the ones that we did were pretty shocking, and I think they're very important. I think we all struggle, though, with how to make that cost effective, and we're seeing more programs use technicians, social workers, and others to visits and then share the information they obtain from those visits back with the medical team. And so there's a few others here that I think some of you have gone through as well, but I didn't want to read every one. I just want to share with you that these can be very helpful for us. Next. Summarize that. We've had some pretty good interest in our programs, both nationally and locally, and have had some recognitions for them. And we're at a point now where we're working with multiple partners with the state in trying to spread this work to other organizations that are interested in adopting comprehensive medication management. Next slide, please. Yeah, Hochman.
Great. So I'm going to talk a little bit about the AltaMed perspective on comprehensive medication management, and then a little bit about the business case and what happened when the grant funds end. And just for those of you who are clinicians, I wanted to sort of give you a sense of what it feels like. So in the traditional model, if I'm a primary care doctor and I have a patient who's got a hemoglobin A1C of 10, I'm going to see that patient most likely, or at least try to see them 3, 4, 5 times over the next 3 months to titrate their medications, to talk with them about diet, exercise, if they start insulin. While doing this, of course, trying to deal with the depression and the shoulder pain and all the other things that come up in primary care. And what having the pharmacist there as really chronic disease managers allowed me to do is to refer those patients to see the pharmacist, and they can telephonically with in-person visits do all the medication titration for me under a collaborative practice agreement, communicating with me so I know when or if they get started on insulin, and then they come back to me in many cases with their hemoglobin A1C under control, and that really freed me up as the primary care doctor to focus on all the other things that I need to do. So it's a very different model. The pharmacists are really chronic disease managers, going beyond the traditional role. And could you advance the slide, please? Okay, so from our perspective at AltaMed, why did we do this? Well, we are facing ever-increasing challenges to care for a growing safety net population of patients. We have aquatic environments. We have a shortage of primary care clinics. And so the question is, how are we going to do this? Next slide. And that we've embraced is the team approach, patient-centered medical home model. So we have licensed clinical social workers so that we can provide behavioral health care to patients right there in clinic. Our sites have RN case managers who can help with various things. Have health educators, promotoras, doing disease education in many of our clinics. Medical assistants, we've been thinking about innovative roles for them as panel managers, making sure that under protocol that the vaccines are done and the screenings are done. Even we've been experimenting with using them as scribes. And then the pharmacists have been just the latest addition to that team-based approach as disease managers. Next slide. Another reason to the team-based approach that we want to do this is hopefully there's not too many doctors on the call. Doctors don't always do as good a job as they should about following evidence-based guidelines. This has been the news all week with the American College of Cardiology AHA conference and the emerging evidence that statins are really the only medications that lower cardiovascular risk and improve heart outcomes. Despite all this evidence and the guidelines, we found that many of our physicians were using some of these fancy, well, maybe not all of them are newer, but the other agents that lower the numbers, that make the lipid panel look better, but don't necessarily have evidence to improve outcomes. And we suspected that pharmacists would do a job of doing what we found as an example, that they were much more likely to use a statin when it was indicated as first line than our physicians were. Next slide. There were a lot of questions when we first brought this program to AltaMed. We got a lot of questions. Can pharmacists do this safely? Well, as Steve alluded to, long history of doing this safely and effectively at Kaiser, the VA, Sinai, and many other places. The primary outcome of our study was, is this actually a cost-effective, high-value service? But it's been well established that this is a safe and effective service. Will they communicate? So as primary care doctors, clinicians, we like to know everything that's going on with our patients, and the pharmacists have done, I think a really important training is this team-based approach and communication and coordination, and that was apparent because they were very good about always making sure that we saw their notes, and more importantly, if they were going to make a substantial change, just walking down the hall and saying, hey, Dr. Hochman, we're thinking about starting insulin on your patient, what do you think? Even though it wasn't required under the collaborative practice agreement, it just created for a more seamless continuum of care. Another question we got more than once, why do I go to medical school? The pharmacist can, administer, furnish medications. And I think this is the answer that we all quickly realized, that this is exactly why you did go to medical school, because if you have a pharmacist who could do something as well or better than you can with the chronic disease management, that frees you up to be a team leader, to deal with the depression and the shoulder pain and all those other things that you did go to medical school for. Slide. Okay, so Steve gave you the hard numbers, but let me just sort of give you the my anecdotal perspective on the outcomes we had. So staff satisfaction, our providers, clinicians, nurses, medical assistants, promotores, everyone loved having the pharmacists there. In fact, the sites that had them were clamoring about halfway through the grant, what's going to happen, how are we going to keep the service when the grant ends, and many of the sites that didn't have them heard rumors that there was this great new service. Can we get one? And if not, can I refer my patients? In fact, we even had a few, more than several instances of patients from control sites being referred to our intervention sites, which was good from a patient standpoint, but not so good from a research standpoint. Satisfaction, the CAS data, but our CEO must have asked me a dozen times, why is it that our physicians get better ratings about their service than doctors, and what can we learn? How can we transmit what they're doing in terms of patients liking the experience of care so much? And my first answer, which I think was wrong, was that, well, USC is a first pharmacy school. I think it's ranked in the top 5 in the country, and we have outstanding pharmacists. And I think that may be part of the answer, but as the program went on, what I actually came to believe, and I think is the case, is the real answer is that patients liked having someone who could focus on their chronic disease. So when the pharmacist sees the patient, they're just focusing on the diabetes and the depression, the diabetes and the blood pressure, and they're able to get to the bottom of it and solve it. When I'm in there, I'm juggling the diabetes and the depression and getting the routine health maintenance done, and I end up doing none of those things well in some cases, and I think it's frustrating for patients. So I think patients really enjoyed having someone who's focused on one issue and actually could get to the bottom of it and would give them a phone call a couple days later to check on their sugar readings and so forth. Quality goals. And, the pharmacists were better following the evidence-based guidelines. To quantify that, the slide Steve showed that they did 11% better than doctors in our usual care sites of controlling the hemoglobin A1C to get it at target, 9% better than doctors at doing tension management. So from my perspective, that is a huge win. If there's something that someone else on the team can do, in this case better than I can, they certainly should be doing that, because I have enough as a primary care doctor on my plate already. Steve showed you the reductions in ER and hospital utilization, certainly in the propensity match control analysis, the readmissions. We inspected benefits. They helped us with patient assistance programs, which are free programs for patients who can't afford their medications. They identified some pharmacies that were having problems with medication errors that we ended up having in some cases to report, and in some cases led to improvements, in other cases didn't, and in those cases the state is involved. And staff education. So, for example, when the new Heart Association guidelines came out, the JNC8 came out, the pharmacists led the way in educating and updating our team, our clinicians on those changes. Next slide. Okay, the really interesting epilogue to the story is what happened when our grant ended. So it was a 3-year grant, 2012 to 2015. This was a win across the board. It improved staff satisfaction, patient satisfaction, quality scores. It appears to be reducing acute care, ER, hospital utilization, although we're still waiting on Jeff Joyce's final analysis. So this is a real win across the board. So it's a no-brainer that we're going to continue this, right? It's never so easy in healthcare, and the question is, how do we make the business case? Who's paying for clinical pharmacy services? FQHCs and in many settings, clinical pharmacy services are not reimbursed. And so we got a lot of pressure from the clinicians who very much like the service, wanted it can continue, and the business folks, the operations folks said, okay, great, but how are we going to pay for this? As we thought through the business case, we asked a couple questions. The first is, does clinical pharmacy save money? And that's the question that Jeff Joyce is asking, is do the savings from keeping people out of the emergency room and hospital actually pay for the cost of the pharmacy services? And we eagerly anticipate the results of this analysis, but I sort of think that's a ridiculous question, because there's virtually nothing that we do in healthcare that is actually cost savings, and to set that as a bar for clinical pharmacy pharmacy services makes no sense. I think the more relevant question is the second one I have here, and that is clinical pharmacy a high-value service? So AltaMed, if you look at our annual budget, it's about $500 million, $500 million a year. It makes sense, given the outcomes we've experienced, that some of those funds should be used to hire clinical pharmacy services. If you sort of had a fixed budget and we're thinking through what's the most efficient way to do this. And I think that question is clearly yes, that are a key part of the team and add a lot of value. So the question is, given our payment environment, how do we pay for that? It's the service that we know is high value, but how in the current reimbursement environment do we support it? Next slide. And so the options that we considered are first, billing policy changes. We could advocate for pharmacists being billable providers, which is a possibility, but we haven't even been able to succeed at FQHCs at getting marriage and family therapists to be able to be billed. So we've been told that pharmacists are after that. And, so I think we're looking at a long time frame on that one. In terms of pay for performance, and certainly with the politics of the state, there's been a lot of pushback for more FQHC reimbursement. So I don't really see that as a politically viable solution. Steve may disagree. Pay for performance, could our pay for performance dollars for improving A1C and lipids and so forth, could those dollars be enough to cover costs to the pharmacists? Perhaps, but if you think about it, I think our total pay for performance dollars last year were about $1 million. So you'd have to argue that the pharmacists were responsible for all of that, and then would even $1 million be enough to cover all the pharmacy services that we need? So that's a little bit of a tough sell, at least now, while the pay for performance dollars are relatively small. Another possibility is the Affordable Care Act has what's called the Health Home Demonstration. I think it's 2703 is the number of it for it in the state. It's basically a per member per month care management fee for doing chronic disease management, and I think that's where we start to be on the track, because that makes a lot of sense. If you have a per member per month capitated for clinical pharmacy services, disease management services, that aligns both with quality and promoting service that we know is effective. And I think the ultimate extent of that is to move away from fee-for-service entirely. So there's been a lot of discussion about reform in FQHC payment models to move to fully capitated risk-bearing arrangements. And I think when we move to that, it would completely open the door for use of clinical pharmacy services and MFTs and all those other things that we do. And it doesn't matter how many billable visits, it just matters how good a job we do of caring for patients. And then that's when we're able to take a step back and say, okay, our budget's $500,000. How much do we want to spend on pharmacists? How many MFTs do we need? And how many doctors do we need? And so forth. The direction, I think that's the road forward for doing kind of grants and medication management. So the epilogue to this is what happened at AltaMed. Well, we ended up doing a sort of neither here nor there compromise, where we ended up hiring 3 full-time clinical pharmacists who are based centrally, and they oversee chronic disease management at the organization, but they don't actually do much direct service themselves. They're still doing the anticoagulation, but instead what we've decided to do is have mid-level providers, practitioners, physician assistants at the front lines doing the disease management, which is workable, and mid-levels, unlike pharmacists, are reimbursable providers, fee-for-service. So that's worked from a financial model. On the other hand, the question has come: is this really the NPA's training isn't really to do comprehensive medication management? So it would just still make a lot more sense to have pharmacists do this role. But that's sort of the compromise that we came up with, and it's working okay. But I look forward to a new payment environment where we can really be a little more systematic about what teamers we use and where. Next slide. Okay, so just a minute asked me to say a couple words at the end about the new Gehr Family Center for Implementation Science that I'm helping to start here at USC. So I just recently finished my tenure at AltaMed and then moved over and took a role to help start the center, which was on a donation. We're building a team. Folks here, actually a couple of graduating fellows from UCLA, Welmud Van Dien, who's been doing some IBD research, and Rusha Modi in the GI fellow are going to be two of the new faculty members. And we still have one or two open positions, so if anyone knows sort of a junior investigator, PhD, or physician, we're still hoping to hire a couple more folks. Next slide. And of our center is to collaborate and partner with local health systems in Los Angeles to help implement best practices, to develop sustainable innovations, and to advance knowledge and care delivery in the process. So I think that the CMMI grant is a good example. As Steve mentioned, it's somewhere between implementation of a best practice and an innovation, because it's something we know works. You know, the question is, how do you make it use this thing that's a service that's becoming a best practice? And that's the exact type of project that we would want to focus on. You know, so the principles of the types of projects that we would focus on are things that align with the triple aim, that improve quality and patient experience, that improve health of populations, the efficiency of care. We want to be co-developing these innovations with systems so that if it's something that works, then it's something that the health system is going to sustain, and it's something that they're very much invested in. We also want to do things that are scientifically important and that engage the university and local communities, and that ideally trainees can participate in. New slide. So just to give you some examples of projects we have going on, the Chief Medical Officer at LA County USC is interested in this new concept of to encourage patients to get out of bed. As we know, so many times patients just lie in bed because it's the only thing that's in their room. And he was wondered, well, what if we put a chair in the room? And the default is that patients spend 20 hours a day that they're awake in the chair, and that they just use the bed for sleeping. Will this help reduce the deconditioning that happens in the hospital? Could it impact readmission rates? Could it even reduce length of stay? So that's a project that we just submitted a grant to test. That's probably more on the innovation side than a truly implementation of a best practice side. We are evaluating the Whole Person Care Initiative as part of the Medicaid 1115 waiver in partnership with Department of Health Services. I know some folks, Arlene Brown and others at UCLA, are we hope to work with on that. Medication-assisted therapy for high utilizers. So DHS has been thinking about piloting Suboxone and other substance abuse treatment programs, and we want to evaluate that and make sure that we're getting the same results in a real-world setting that have been seen in sort of the experimental studies. Another one with John Snow Incorporated on preventing readmissions from the primary care perspective. So similar to the sort of Coleman model, what can you do on the primary care side? What systematic processes can you have to reduce readmission rates? That one's at AltaMed. And then, of course, scaling up comprehensive medication management. Steve and I have been now working over on the KEC side to see, and Steve's really been leading those charge, that charge to see if we can get similar disease management services in the KEC health system. Slide. The last slide I have here is just we're going to be releasing some innovation awards, a couple pilot grants, $25,000 each. They have ideas that they want to pilot that could either lead to a sustainable best practice where that would not previously, or alternatively, might lead to a larger implementation science grant. So we just released those. If you're interested in that, let me know. It's open to anyone who's innovating in the Los Angeles area. We also have a similar program for UC students in any health discipline. And we're hoping to get a group of 4 to 6 fellows together this year and get them a list of group projects that they're working on to align with some of the work we're doing at the Gehr Center. So with that, I think that's my last slide, and we'll open it up to questions.
Great so much to both of you. That was fantastic. I think we'll open up the open the calls line so that everyone can ask any questions that you have, and or if you want to put a question in that box, we can also handle any questions that way, and we'll get them to our speakers. I might just ask a question to kick things off. Also, if you do have ambient noise where you are, if you could mute your line if you don't have a question, that would help us make sure that we can hear the questions that come in. I wonder if I could kick it off with one quick question to both of you, and this is back to the example that you had of the pharmacy intervention. I was wondering if you could comment on the extent to which measurement is continuing, that you shifted the intervention post-funding in terms of the role of the pharmacist. Have you been able to, or will you be able to continue or AltaMed will continue the process of measurement, and is it happening in the same way or in a different way than it had in terms of looking at data and run charts, or other measures, perhaps other ways, perhaps if you don't have a control group in the same way you had during the intervention period?
This is Mike. I can.
And sorry, I think someone's got some ambient noise, so if you could mute your lines, that would help a lot. Sorry.
It's a great question. What are we doing with the data analysis now that we've sort of moved out of the CMM grant phase? I think it's unfortunately the usual story where we become much less scientific and systematic about evaluating what we're doing, not looking at control groups. So, we have data, we're sort of tracking proportion of patients who have A1C control change at the sites that we've been implementing this new model of care, and kind of comparing it to the control sites that don't yet have the services. But we've certainly been less systematic in looking at it more from a quality improvement perspective, because of course many of the measures that we're looking at, A1C control, blood pressure control, are key HEDIS measures, which are things that AltaMed is very concerned about and focused on improving.
And we do have questions on the chat. The question is, do you have plans to evaluate difference in medication management outcomes by the pharmacy versus the nurse practitioner or physician assistant?
Fortunately, we won't have that opportunity because we phased in the nurse practitioner model just as the pharmacists phased out. It's a really good scientific question, but we're able to answer that one, at least in a head-to-head fashion. I guess we'll have some data on how good a job we are of controlling A1C at a population level as part of the CMMI, and now subsequently, although I think it's confounded by the fact that AltaMed is just becoming more and more focused as each year goes on at improving on our HEDIS measures and being more systematic about screening and reaching out to people who have poorly controlled diabetes. So I think it would be really hard to get a good scientific answer on that question.
I don't have any more on the chat for now.
Great. Are there any other questions for anyone on the call? Any more speakers? People are coming up with any questions that they have. I wonder just if I could do just a quick follow-up on measurement. I was wondering if you could just comment a little bit about that, particularly as AltaMed, as a learning healthcare organization, that idea, as you're saying, of you move from the period where you might be looking for the unique impact of what's the specific contribution of the pharmacy change to come up with the cost information that you need to justify certain kinds of decisions, versus moving to how do we optimize the roles that we can provide currently with the existing payment structure and the existing staffing structure. It may not be optimal, but it's what exists. Are there ways of looking at the variation, tying patients to where they got the medication management, so you can, I think you were just answering this, but I wonder if there's anything more that you would want to add about being able to do this again using information for improvement, but still learning from the existing data that you have, tying patients to particular kinds of care providers or particular groups of, whether it's PA or whoever might be doing that management, and trying to look particularly at variation across groups, any learning from that. Or as you said, it's moved to a QI phase where it's one of the things happening.
I've actually, I think it's one of those really interesting things, or what happen in real-world settings when there's not a grant to provide support for funding, and that's one of the things that theoretically we're trying to do with the Gehr Center is to evaluate things in real-world settings, not in experimental type settings. And I think it would be a really good, interesting question. We started the nurse practitioner disease management efforts in, I think initially it was 6 sites. Now it's up to 9 sites. AltaMed has 30 or so primary care sites, and it would be a great evaluation to really do a difference in differences analysis at A1C control and blood pressure control. And because AltaMed uses an electronic health record, it would be relatively easy to do. So that's not something that many community health centers like AltaMed are going to just do for the sake of doing it. But that, I think, is a great opportunity for academic partnership, and where research would come in and really would help AltaMed and would also provide scientifically valuable knowledge. So I think it's a good question to raise and to put us on thinking about how we could do that.
If I could just comment briefly on that. It was already mentioned by Dr. Hochman that Kaiser VA has done this for decades, and although they don't look at their data as an academician or researcher would, it's clear from that experience that, and I'm trying to phrase this carefully, we're really not competing with practitioners or PAs. The roles are quite different. The focus, not have folks that lead many of the efforts in Kaiser. And what I'll tell you is, what pharmacist brings to the team is 4 years plus of focused concentration on studying medications. And expertise is unique to the team. So we complement what everybody else is doing. And when it comes to the very high-risk patients, when it comes to medications, we're really the right fit. And I know this is very non-academic statement, but it's one of the things I think we struggle with. We just, in terms of implementation, we want to make sure the message isn't we're going to have pharmacists to replace people. It's to fill in a gap that really isn't being addressed much at the moment. And I think our 11.5 medication-related problems for patients highlights that.
And we have a question in the chat for Dr. Chen. It's actually like 2 questions in one. The first one is, how common are clinical pharmacy positions in general? And is this very unusual for pharmacists? Brackets most are in retail practice, or do other systems use similar models?
That's a great question. Yeah, so to address the first question, clinical pharmacy positions, in capitated health systems like the Kaiser VA, they're extremely common. They've become much more common over the years as risks has become borne by the provider groups. For example, Cedars-Sinai, I helped start their program, maybe 15, 16 years ago with 2 pharmacists, now 16, and full-time that are providing clinical pharm services for Cedars-Sinai Medical Group. Same is happening at Sharp, at other major medical group systems. So that there are plenty now, and they're growing very quickly. But I think the second part of the question is hitting on probably the most important aspect of this, and that's the fact that community pharmacy is not known for this at all, right? Because reimbursement for community pharmacy is largely driven by the product, by prescription volume. That's changing now, though, as a bill was signed by the that recognizes pharmacists as healthcare providers. And the intent of that bill, a large part of it, was to make sure that pharmacists that were not physically integrated into a health system, such as in a community pharmacy, could start to offer some of these services. I think one of the questions that comes up is, are pharmacists in that setting qualified? And I would say that pharmacists that have been practicing in very much a dispensing role for years and years and years probably are not going to do this and will not be able to do this, because the way the bill is regulated, it requires a certain type of credentialing and competency to fulfill the criteria of an advanced practice pharmacist. But for those pharmacists that do qualify, and that means having a residency program, having having board certification, they meet 2 of those 3, can do similar services as what we're describing in this program that we do. But I think one of the remaining challenges will be sharing of health information, because a pharmacist is not going to be able to do a good job and then make good recommendations or changes if they're not in the loop of that information. But I see that as the next phase. That's where it needs to spread to.
Could you maybe say a word about the summit in Sacramento you were at yesterday?
That's right. I'm sorry. I should have mentioned it. The California Pharmacists Association helped sponsor a bill, an assembly bill, that went into its first phase yesterday at the Committee on Health. Senator Jim Wood is the sponsor, and he asked me and the California Pharmacists Association CEO to testify on it. So this is basically step one in proposing that comprehensive medication management be a mandated benefit for high-risk Medi-Cal patients. So in the hearing, basically we shared this experience that you heard today. Primarily, that was the main testimony, and we got a 15-0 vote in favor of moving this forward, which means nothing until they get to the money part, right, the appropriations and everything else. But at least it seems there's a great interest in supporting this work. So we're hopeful.
Great so much. I just want to mention there might be time for one other question, but in the meantime, we're about to release the evaluation of the call, so we'd really appreciate it if everyone who joined the call today could fill out those brief questions very, very quickly on the poll. So I think we just released to everybody right now.
Yeah, just now, yeah.
Great, thank you, Hima. Any other questions or comments from the call? Any last comments that your speakers would like to share? Well, it's always wonderful when we can end on time and give people time to actually complete a poll. So maybe we'll do that. But just wanted to thank you both so much. It was really really fantastic. Raised a lot of interesting questions and a great study example of. I really appreciate the epilogue as well, to be able to see what happens after and how the world of science can continue after the 3-year period is up.
Thanks for having us, inviting us.
Thank you.
Great.
Thank you.
Yeah.